Hello and good afternoon. I was about to say good morning, but we have crossed that by 2 minutes. I wanted to thank everyone today for joining us for this media briefing on what we have learned from COVID-19 pandemic as we near the 6-month mark of the first confirmed case in the United States, and how it will inform us and how we can continue moving forward. Today, for this presentation, I will be your moderator. And if you saw that long, complicated name, I'll walk you through it. I'm Hopkins, an assistant professor in the Pulmonary and Critical Care Division. I am a physician as well, and I also happen to be the co-chair of the Johns Hopkins Health Equity Steering Committee under the guidance of the Office of Diversity and Inclusion. Today, we'll have the opportunity to hear from many Johns Hopkins experts on what we know about the virus thus far, what we are experiencing now in terms of health disparities, especially in our vulnerable populations, and what reopening society looks like, and as well as some potential therapies. All of the speakers today will give presentations for about 5 minutes, and you'll have the opportunity to ask them questions through the Q&A feature of Zoom. I, as the moderator, will be looking at the questions coming in. I'll be able to make note of it, and then I will be asking the panelists these questions at the end of our session. So keep them coming as they come in. The speakers will take the questions that you've submitted, as I said, at the end of the briefing. We'll start the briefing by discussing the lessons we've learned and where we are headed. So since the start of the year, the scientists that I can call a lot of them my colleagues here at Johns Hopkins and around the world have worked tirelessly to understand this virus, SARS-CoV-2, the virus that causes COVID-19, as well as how it spreads, how it mutates, and what potential therapies we may have. So this is a virus that we have now known for a little over, closing in on 6 months from the first US case. It's been around for probably up to about 8 months. I say this because as an academic physician, it is always awkward to be called experts after you know something for such a short period of time, but here we are adapting to the moment that we are in. So with that said, we're gonna go ahead and kick off this hour with our first panelist. I'd like to introduce Lisa Margakis, Senior Director of Infection Prevention at the Johns Hopkins Health System, who will discuss what we know about the disease and what the projected trends are. Lisa, I turn it over to you.
Thank you very much, Panagis, and thank you everyone for joining us today. I just want to take a few minutes to say some general remarks about where we are, what we've learned, and a word about where we think that things are headed. So now that we are about 6 months into the United States response to COVID-19, we see that worldwide there have been over 8 million cases and over 440,000 deaths. In our country, there have now been over 2.1 million cases and more than 117,000 deaths. And the numbers, I think, are staggering, but they really belie the more concerning thing, which is the trends that we are seeing. So one thing that I really want to highlight today is the fact that there has been much discussion of a second surge, and of course we have prepared and discussed the possibility of a second surge. Usually by this we mean something that will come in the fall when we have respiratory virus season, and we know that we are at risk for a resurgence of COVID-19 as well. However, one point of emphasis today is that we really are still in our first wave of this pandemic in our country, and there is an uneven distribution of the increases that we see currently, but almost half of the states in our country are seeing increased numbers of cases. Unfortunately, I believe that this is largely due to some of the reopening activities that have happened, and there is concern that we have seen a plateauing in our country of the number of United States cases of COVID-19. In addition, I would point to a concern over misinformation that continues to circulate, as well as a lack of a cohesive, consistent public health messaging about what we need to do to get through this enormous challenge and crisis in which we find ourselves. So we have several challenges that are ongoing, including testing capacity, which has improved, but remains a challenge in many areas, and a very uneven and uncertain supply chain that continues to cause problems with access to personal protective equipment, as well as other critical supplies such as disinfectants, alcohol-based hand gel, and laboratory reagents in order to perform the tests. So while I say that we have come a long way, and as Panagi said, it actually has only been 6 months, so this is a relatively new experience that we are having with the virus. We have learned a great deal. You will hear today from my colleagues about the effects in children that have now been recognized, about some of the clinical effects that are multi-organ. So it is not just a respiratory virus that causes multi-organ damage, about the startling and stark healthcare equity issues and disparities that we see arising in vulnerable populations and minority populations. But I think that one of the main messages that I have been trying to convey to those in our own organization and our own community, and I think that our nation and really the world would benefit from realizing that there is a long time delay between a policy change, a behavior change, and when we see a signal in population level data. And what I mean by this is that when a state or a location changes a policy, reopens, for instance, some of their businesses, or moves into stage 1 or stage 2 of their reopening plan, many of us look in the ensuing week or two to see if we see effects. We're doing this now in light of the many protests across the United States, in light of the death of George Floyd. But what I want to emphasize is that when you're looking at population level data, such as the number of cases, the number of hospitalizations or deaths, it takes a number of weeks before you see that signal. And so we need to keep this in mind. And I think that's part of what we're seeing with the increases in some of the states that were the earliest to open. So we are not out of the woods yet. My message would be that we need patience and perseverance to get through this crisis, and to focus on the very basics of infection prevention practices that we all know so well, like hand hygiene, masking, and social distancing. And it is possible to reopen while doing these things. So I think I'll pause there in the interest of time.
Perfect, perfect. Thank you so much, Lisa. And again, at the end of the briefing, we're already getting a few questions for you, so we will tackle those and I'll direct them towards you, but thank you. It's hard to say it's a great beginning to a conversation about a pandemic, but I think your clarity and insight is valuable to recognizing that we're still in this pandemic. So thank you, Lisa. Our next topic of discussion is children and COVID-19. What are we seeing? COVID-19 affects everyone, but manifests differently in children, and there has been a rise in the numbers of children who need aggressive treatment due to COVID-19. Therefore, it is my honor to introduce you all to Aaron Millstone, Professor of Pediatrics at the Johns Hopkins University School of Medicine, who will share what he is seeing in practice, as well as what we know about multi-system inflammatory syndrome in children, a condition that can cause inflammation in a variety of organs, such as the heart, lungs, kidney, and brain. So without further ado, Aaron, I turn it over to you.
Great, thanks. Thanks so much for joining us today and letting us get, I think, some important messages out. When we were reflecting back on 6 months into this pandemic, but one thing that is most striking is how we've all had to cope with uncertainty. This new virus started with many unknowns and has continued to challenge us in the healthcare and public health communities with a lot of what we don't know. We've learned a lot over 6 months, but there's still much left to learn. What have we learned? Well, we've learned new ways not new ways, but we've learned how to adapt our strategies for prevention. When, as a pediatrician for years, I wouldn't have expected to see so many children walking around our communities and on playgrounds wearing masks. So we've taught a new generation of safe infection control practices during times like this. We have kids that are wearing masks. We have kids that are appropriately socially distancing. They're finding clever ways to play with their friends, whether it's realizing that there are fun ways to play that are safe, that'll protect themselves and their communities. So I think one of the nice things that we've seen about this pandemic is the creativity and resilience of families as they've really adapted to the new norm, or at least the norm for the short term and even for a little bit of a longer term as this pandemic goes on. But to see kids still being kids and finding ways to get out and be safe, but still heeding to those important social principles that Dr. Maragakis mentioned, that have been really put forth by the Centers for Disease Control and Prevention and local health departments. Initially, when COVID pandemic started, many people were relieved, thinking that kids were being spared from this disease. We had reports of kids having mild illness, but early on, reports did not show significant illness in children. What we've learned now is that there is a post-COVID syndrome, as was mentioned, this multi-system inflammatory syndrome in children associated with COVID-19. This is a syndrome that was initially reported out of Britain and other countries, and now has been pretty widely recognized in the United States with hundreds of reported cases. And this is a really serious complication of this pandemic for children. Fortunately, this remains rare, but it is concerning. We have seen kids hospitalized, many kids hospitalized, and even some who've died from this post-COVID syndrome. And what it really needs to remind everyone is that we are still learning about this virus and what it can do to the body, as Dr. Maragakis, not just the lungs, but other parts of the body. And we need to continue to follow precautions to keep not just what we thought of as initial vulnerable populations like nursing home residents and elder adults, but we also need to keep our children safe as well. So right now, there's no one that is being spared from this pandemic. We really need to make sure our measures continue to protect everyone. As was mentioned, we're getting lots of questions now about reopening, especially for children. What does this mean for camps? What does it mean for sports? What does it mean for schools? People need to start to accept that things will look different over the next 6 to 12 months. Camps will look different. Schools will look different. Classroom sizes may be smaller. The days may be scheduled differently. There may be hybrid models of learning. We're hoping and encouraging people to be patient and amenable to changes that will not only allow kids to be kids and have fun and play and learn, but that will also keep them safe. And I guess that is my last message that I think Dr. Maragakis also ended on, is the need for patience. We know that we will continue to learn. Recommendations will continue to change and adapt as we learn. No one is immune to this virus. So I would just encourage people to continue to be smart and follow recommendations that are put out by both the CDC as well as state and local health departments, so that we can keep our communities safe, as well as reopening to allow people to get back to, especially kids, get back to education and fun play with their friends.
Excellent. Thank you so much, Aaron. Great points. And one comment that you made that I really like to emphasize, because as Lisa laid it out for us early in this conversation, we're all learning about this virus in real time. And so whatever recommendations we make today, June 17th, may look differently. after about a month. I remember in late March making the comment, no, face masks only for those with symptoms, and then several weeks later, we reversed that. So the pace of science has been expedited during this time, and we're all in this together. I think that's just kind of my closing thoughts after your conversation, Erin. With that said, moving on to our next panelist. It's actually really a great person that I get to have the honor to always work with in the last several months. So COVID-19's pandemic has had more impact and grave impact in regards to the conversation around health disparities, especially across socioeconomic status, ethnic status, as well as racial status. Not only is the mortality rate of African Americans from the disease higher than any other group, but systemic racism also puts their lives and health at greater risk versus their white counterparts. It is my pleasure to introduce you, as I said, someone who I value as a mentor, and we get to work together a lot, Sharita Hill Golden, Vice President and Chief Diversity Officer at Johns Hopkins School of Medicine. And Sharita will discuss the importance of addressing these issues now. Sharita, to you.
Right, so thank you, Panagis, for that wonderful introduction. So I just wanted to be able to share with all of you, one aspect of the pandemic that unfortunately is not a surprise to many of us who've worked in the field of health equity and health disparities for years, is that this pandemic has had a disproportionate impact on our African American and Latino as well as Native American communities. And so just to give you a sense of the numbers that we've seen, so if we look at the death rates per 100,000 people from coronavirus in the United States, for Blacks, there's been about 61, 62 people that die per 100,000. For Native Americans, about 36 who die per 100,000 compared to about 26 that die per 100,000 for whites. So, we're looking at death rates that are at least almost 2.5 times higher in those particular populations. And if we look at who's had the highest overall mortality, it is actually our African American population. So out of the almost 120,000 deaths that we've seen now, there have been just over 25,000 African Americans who died. So really 21% of that deaths, but African Americans really make up 13% of the population. So in many cities and municipalities, the rate of death, or the proportion of deaths among African Americans really far outweighs their proportion in our states and our cities where we have collected data. Washington, D.C. has actually had the highest rate of death, and the rate of death of African Americans is not just higher compared to whites, but also even higher compared to our Hispanic population. And so what's really interesting is that we're at the 6-month point now, and so these disparities became very apparent early in the pandemic, and this has been a pattern that's been persistent and consistent throughout the pandemic, and we're still seeing it today. So one of the things to point out is I mentioned that African Americans have the highest death rate, and but in our Hispanic population, the death rate is not higher compared to whites. But I will point out that the infection rate in the Hispanic community, or the conversion rate to COVID positivity, is higher than it is for whites. So, so that is one reason that we have particularly been pushing to make sure that those communities are screened and informed, because they have a very high infection rate and then can also pass that on to additional vulnerable populations. So one question you might ask then is, if there's a high infection rate in both the African Americans and the Latino population, why is it that African Americans are the ones that are dying at a higher rate? And Dr. Galeazzi-Tost alluded to this in his introduction, but there is a burden of comorbidities that African Americans have. So higher rates of diabetes, hypertension, cardiovascular disease, lung disease. And at the beginning of the pandemic, there was really a focus that these are the reasons for the differences in mortality. But then I think we have to step back and say, why are there these differences in mortality? And so I really think of these in a couple of buckets. So there have been sort of medical and health system historical contributors. And so You know, for many generations, there was a eugenics theory that said that African Americans and other non-white populations were biologically inferior, and these were persisting even until the 1950s. Now, we all know today that none of that is true, but unfortunately, that bias has persisted in our system. In addition to that, we know that a lot of our underserved communities were experimented on without their consent. And this happened in African Americans as well as Latinos. So we've heard of the Tuskegee syphilis experiment in African Americans, but there was also a Guatemala syphilis experiment. And so that means that these communities are less trustful of the healthcare system and won't come in for preventive treatments. And then the final thing is that when there was the closure of medical schools in the US following the Flexner Report in 1910, you know, that closure resulted in a lot of medical schools being closed. But what that meant for those who were studying to become Black doctors, that of the 7 medical schools that existed, only 2 were left after those closings, and that was Howard and Meharry. And remember, this was at a time where those who wanted to become Black doctors could not gain access to predominantly white medical schools. So this means that there's been a shortage of Black physicians to care for and advocate for the population. So many of our populations still experience biases in our healthcare system. So even if they have insurance, they may be less likely to come because of concerns out of their experience. And then there are, of course, the social factors that have contributed to structural and institutional racism. So redlining that happened in Baltimore as well as other cities that resulted in racial residential segregation. And what ended up happening is that there was a lack of investment in public works, in infrastructure, and parks and schools in those communities. And unfortunately, there was also predatory lending practices. So that has resulted in us having many of our African American and Latino communities living in neighborhoods where there aren't green spaces, there's not access to healthy food, they have increased exposure to pollution. So all of those things increase their risk for chronic diseases. And then finally, there's the increased risk of COVID exposure in those groups. And so many of our African American and Latino populations, as well as our Native American populations, were considered essential personnel in this pandemic. So not our physicians and nurses, but our environmental service workers, food service workers, transportation, security, all of these positions that were crucial, but people who were employed in many of those arenas did not have personal protective equipment at the start of the pandemic. And so they were more likely to become infected. And in addition, many of them live in crowded housing for the reasons that I outlined previously. And then we also know there's also mass incarceration of African American men and Latino men. And so again, this is a crowded situation where there's often inadequate sanitation. And so that can lead to the spread. So, it turns out that because of all of these experiences, there's increased exposure and poorer outcomes with COVID. But then because this has happened over 401 years, that has actually impacted the biological responses of these groups so that they're more prone to death. So I think that's why we're seeing higher death rates in African Americans, say, compared to the Latino community, which sort of has immigrated here more recently. So the last point that I want to make, and I think this is a point that Dr. Maragakis and Dr. Millstone have brought up, is that we are still in a pandemic. And so following the death of George Floyd, there have been a lot of protests. And really, if we think about what's at the root of the protests about police brutality, and then we look at the COVID disparities, they really have the same root in the structural racism and the discrimination, and that's really what everyone is trying to address. But we've got to do this in a socially distanced, appropriate way using public health measures. So, it is really important that people who are participating in protests wear masks, that they socially distance as much as possible, that they engage in hand hygiene, so having lots and lots of hand sanitizer, and then also wrapping a cell phone in plastic. These are all important preventive measures, because remember, even if it's a younger generation that's out doing a lot of the protesting, that they can be carrying coronavirus back to other vulnerable individuals in their communities. So it's really important to recognize that while we have a public health and a civil rights crisis going on simultaneously, that we've got to be responsible in implementing the best public health practices. So I think I will stop there.
No, Sharita, and I love the closing point that you made. Focusing on one public health concern shouldn't blind us from another public health crisis. And we can definitely walk and chew gum at the same time. So thank you for that insight. Next, as states begin to reopen, contact tracing, a public health tool that identifies and alerts those who may have been exposed to disease, will play a critical role in containing COVID-19 alongside social distancing and widespread testing. Crystal Watson, a senior scholar at the Johns Hopkins Center for Health Security at the Bloomberg School of Public Health, is here to explain how to expand contact tracing in the United States so that we may reopen society safely and mitigate additional waves of surges from the disease. Crystal, the panel is yours.
Thanks very much, Panagis. I appreciate it. I'm going to share my screen. I have a few slides to present. I'll see, I think I cannot share there. Let's try again. Okay, well, while we're getting
Crystal,
that,
I think it actually popped up. You just had to pull it up when it looked like it was at the bottom of the screen when you hit share.
okay.
Try it again. I thought I saw something pop up at the bottom of the screen.
Sorry about that. It says you cannot share screen while another participant is sharing.
Okay, no worries. Do you want to try to just walk us through the presentation?
Yeah, I can do that. Oh, there we go.
Perfect. Thank you, Crystal.
Okay, thanks a lot.
Oh, it's there.
There we go.
you are.
Okay, thanks very much. So I wanted to start just by talking about where we are in the phase of the response, to reemphasize what other presenters have said already. We think there are approximately 4 phases to this pandemic response. The first is phase 1, slowing the spread. This is the phase that we've all been in over the last several months. Now we're transitioning into phase 2, which is this phased reopening, moving into releasing some of these social distancing measures that we've become so accustomed to. Then I won't belabor these, but phase 3 is establishing immune protection, and that is working on the vaccines and treatments that my colleagues have discussed already. And phase 4 is, after this pandemic is over, then preparing ourselves to respond in an even more effective way during the next emergency. So one of the big emphases that I would like to make is on contact tracing. So this capacity is needed, especially as we start to open up, we start to release our control over social distancing measures like stay-at-home orders, which is what we've been using as kind of a blunt instrument to keep people at home and keep them distant and avoid more transmission of this virus, to reduce the transmission at a population level. But we need another tool in order to replace that once we start to release those measures. So that is contact tracing. This is a way to manage the spread of the virus on a case-by-case level. And this capacity is needed to break chains of transmission. So if we ask people who have been exposed to stay at home for 14 days in quarantine, that can stop the transmission with them. To manage the epidemics of COVID-19 in an ongoing way, in a more manageable way, and to prevent future waves or surges of cases. As Dr. Margakis said originally, that we're not really out of the first wave yet even. We're all very concerned about the fall, but we're seeing surges of cases now. And so we need to build this capacity so we can manage this in a more effective way. So how do we do this? We need a massive workforce upgrade for contact tracing. This is not an easy thing to do. We've never scaled up a public health workforce to this level before. We think there may be needed as many as 100,000 new trained contact tracers across the country. We also need coordination, guidance, and support from both the state and national levels in public health. And we need training and community collaboration to do this work. I'd just like to point you all to a training course that colleagues at our Johns Hopkins School of Public Health have developed on Coursera. That's if you go to Coursera website and search for COVID-19 contact tracing, it's an excellent resource to begin to train people to do this work. So we're making progress on this across the country. We're not there yet, but just as an example, because we're in Maryland with Johns Hopkins, this is an excellent report from NPR that's being updated currently. But Maryland had planned as of mid-May to have about 16 contact tracers per 100,000 residents. The estimate has been that we need about 30 per 100,000 to respond to this pandemic effectively. And so as of the end of May, Maryland had scaled that up to about 1,400 contact tracers total. So we're making progress. This looks similar in many parts of the country, but we're not there yet. So I just wanted to highlight that now as we're starting to lift these social distancing measures, as we've all been thinking about, there are some hotspots arising across the country where transmission is increasing after these measures are lifted. And so just keeping an eye on these data, on this information about case numbers, as well as the clusters of cases that we're seeing around the country. I think there are specific settings, as you just heard, I think in the chat, the long-term care facilities have been a particular setting that have been very deadly for outbreaks, but we're also seeing other settings like other institutional facilities, corrections facilities, jails that have had large outbreaks. As well as some industries like the meat processing industry, where social distancing is a little more difficult. And so we need to work hard to get better control of the virus in these settings, because I think they are driving a lot of the transmission that we're seeing. And so this is from the Johns Hopkins MAP website, the coronavirus.jhu.edu, and this is tracking testing trends as well as trends in new cases. And so we need to be looking at these indicators very closely over the next few months, not just into the fall, but now to understand what is happening with transmission and how we can gain better control of it through things like testing and contact tracing. And so that brings me to where we are going in the fall. As I said, I think we're definitely not on the downswing nationally. There may be some parts of the country that have really reduced transmission and may be able to keep that going down in the next several months. But as we're seeing in many locations around the country, transmission is increasing. And so we expect that to continue. We hope that we can build these public health measures to manage outbreaks in a better way. But right now, we're not seeing sufficient control of epidemics in a number of places in the country. So I think we will continue to see a trend up, and then there is concern in the fall in particular, not only with coronavirus, but also with the return of the seasonal influenza and other respiratory illnesses that we have in the winter months. And so we need to be very careful to watch these data and to continue to work to build our capacities to manage this going forward. Thank you.
Crystal, thank you so much. And I love how you came right after Sharita. So both of you kind of put two very great perspectives together, that if we're going to really tackle the pandemic together, all of us, and bringing our unique skills, bringing in data, bringing in the health equity lens, all of it is going to be able to help promote the guidelines that Dr. Maragakis lays out, as well as making sure all of our populations from children to adults are well protected. So great, that's a great transition. And then finally, to end our panelist speakers, we always save the best for last. I tease, everyone has been fantastic. It just happens to be how the order goes. So convalescent plasma therapy. It leverages the immune system components found in the plasma portion of blood from people who recovered from COVID-19. Shmuel Shoham is an associate professor of medicine at the Johns Hopkins University School of Medicine, and he will discuss the effectiveness of this approach as a potential therapy, potential treatment for COVID-19 patients. Shmuel, over to you.
Thank you. I'm going to try to share my screen. If it doesn't work, then that's okay. Did it work?
Yes, I was giving you a thumbs up. It's all you, my friend.
Great. All right. So I'm going to talk about 5 categories of patients, and they really fit into what everybody else has been talking about and where we go forward on the therapeutic side. So pre-exposure, that's people that have not been exposed yet, as far as they know, but are at risk for exposure. So some of the population, some of the people that you've been talking about that have to go and work as workers in a place that does not have the capacity for social distancing. So, and that could be somebody working at a meat packing plant. That could be a sailor on a submarine, and that could be environmental health services worker who is using PPEs, but nothing is perfect, and there could be a pre-exposure. Typically, that has been the place where vaccines work, and we of course want the vaccine as soon as possible, but that's not here available today or soon. The next person is post-exposure. That's a person who's had a significant exposure. So, for example, again, somebody working in a poultry plant or somebody working as a healthcare worker who's then had a specific exposure to an individual who is infected. That can also play out in a row house in Baltimore where somebody comes in and they are infected, and it's very easy for us to say, oh, social distance. Well, what if you have one bathroom and 6 people in the house? It's harder to do social distancing. So that's post-exposure. Next, we have early infection, and that's people that are sick, they feel miserable, but they're not quite sick enough to be in the hospital. We move on to moderate infection, where now they have hypoxemia, which is the medical term for low oxygen in the blood, and they require hospitalization. And then finally, severe infection in an intensive care unit. And I've been touched with this myself. One of my beloved teachers when I was younger, she ended up in the intensive care unit and because of coronavirus, and many of us have had people like that. That we know. This is a slide that was put together by one of my colleagues, Dr. Allwater, and it looks at the timeline. So all the way on the left, you have the person that's exposed and then becomes infected. That's at day 0. And then they move on to having feeling miserable, fevers, cough, muscle pains, and then sicker and sicker, and then hopefully recover. Antiviral therapies, and the most famous of those is going to be remdesivir, which was one of the things that was studied at Hopkins and elsewhere, may work there and may work best before the person gets really, really sick, and then perhaps the damage is too far gone. Convalescent plasma, which I'll talk about a little bit more, that's a form of immune therapy. So typically the way a vaccine works is you get the shot, your body makes antibodies, and then your antibodies protect you. Here, because we don't have a vaccine yet, you can take people that have survived the infection, harvest their antibodies, and give them to people that either are at risk or already have the infection at that early stage. And again, like antivirals, the best time to do that is early on. We're getting more and more data as to exactly which patient it's best in, exactly what kind of plasma is the best plasma, which one has high octane stuff, which one is not as strong, but that's where convalescent plasma fits in. Then immune modulators, and we've recently heard a press release of steroids perhaps making a difference, but there's a lot of immune modulator therapies that make the immune system less active. We've heard about the cytokine storm, and that's where the immune modulators worked. And putting all that together, for example, at Hopkins, we have over 30 research projects looking at coronavirus and the various biological aspects of it, and 14 clinical trials. So every single one of those periods that I talked about, before exposure, at exposure, after exposure, and when people are already in the hospital, we're looking at with hundreds of clinicians, scientists, and people that are coming together to try to find out where it works, what works best, and then there's been pouring in, and of course more is going to be needed as we come to deal with this challenge. So now homing in on plasma. So the fundamental concept is that plasma is the clear liquid part of blood, and you might have heard of serum, and serum is basically plasma without clotting factors. So sometimes people talk about serum therapy, plasma therapy. It's essentially the same thing. and you obtain it through a process called plasmapheresis, which is very similar to a blood donation. And we give it to people every day as something called fresh frozen plasma. It's a very commonly used product. The only difference between the plasma that we're using for this and the plasma that's normally given is that the plasma that's normally given is just given from regular blood donors, and the plasma that is given here is for people that have survived and recovered from coronavirus, so that they have antibodies against coronavirus. And here's a picture. There's some whole blood. It's red because of the red cells. You centrifuge it, you spin it down, the red cells, erythrocytes, go to the bottom, and the plasma, that yellowish clear material, goes to the top, and that's where antibodies reside. And as part of the healing process from respiratory viral infections, people make antibodies called immunoglobulins. And that antibody, again, is what you can harvest through the blood donation. And it's found in, and then the plasma can be given to people. I can tell you that people can absolutely come together to donate it. The Orthodox community in New York City has punched way above their weight in that they were very hard hit by coronavirus, and they got together and organized and donated so much plasma in New York City that New York City said, we don't have enough places for you to donate. So they drove to Bethlehem, PA, and donated there. And I think other communities through their churches, synagogues, mosques can also get together and do this to help other people. Here's a little bit of a timeline of activity. So on February 27th, my colleague at Hopkins, Arturo Casadoval, wrote an editorial in the Wall Street Journal with this idea. And he said that in the past, people have had infections and plasma has helped them, and maybe we can do this for coronavirus. And that excited a lot of people at Hopkins, and we got together on teleconferences and said, how do we turn this Wall Street Journal editorial idea of a historic approach into something that can be used now? And a grassroots efforts of investigators here at Hopkins across the country got together. We created a website because people were so excited about this idea that they were emailing us for, what are you doing? What are you thinking? And sometimes we were getting emails from people in the same hospital, in the same department, asking the same questions. So we created a website to put all the information together to develop the protocols, match donors, and collect plasma. And from the beginning, the approach was very much open source. You wrote a protocol, you shared it with people, people made it better, sent it across the country, and there was there were no egos involved. And we aren't companies, we aren't a pharmaceutical company, so we don't stand to make money from this. So we said, yeah, sure, go ahead, here, take this and make it better and use it where you are, or develop it further. The FDA was open to this approach and was able to grant an investigational new drug for randomized controlled trials. They did it faster than ever. And just sort of wrapping up, the two studies that we're doing here for early, which is post-exposure prophylaxis. That's the one that says, have you been exposed to coronavirus? And then for people that could be in the hospital, you can see the posters for those. And if anybody is interested in being part of the trial or learning more about the trial, the website is COVID, COVID, plasma, PLASMA, trial@jhmi.edu. That's our email, or covidplasmatrial.org. That's our website. And with that, I'm just going to finish with one last slide as to where it all fits in. So coronavirus is plasma. That's right where we are now. We have it. We are testing it, and it's available to protect, hopefully, people right now. There will be better products, hyperimmune globulin, which is a concentrate of it, hopefully coming down the pike pretty soon. And then, of course, we're all looking for an effective vaccine that then we can celebrate with the adult beverage or non-alcoholic beverage of our choice when it becomes available. The convalescent plasma research is going to help to improve the hyperimmune globulin research, which will hopefully get us to a vaccine sooner. And that's kind of where we stand, and very proud to have been part of that at Hopkins with hundreds of people involved. Thank you.
Excellent. Shmuel, fantastic. I think what I've taken away from your presentation is to make sure I buy a bottle of champagne now for when we have the vaccine. So that is on my to-do list. So you all have been fantastic. And now I want to be conscious of the hour. We're going to transition into the Q&A. And we've been getting fantastic questions. And I'm going to be biased as an ageist. Let's ask a pediatric question first. So this to you, Erin. How far should you open your social circles when it comes to letting your children interact with other children and kids?
A lot of this is coming down to individual people's risk tolerance. I think informing yourself about what the prevalence is of COVID in your communities. We do know that even within Baltimore City, there's some zip codes and neighborhoods that have higher prevalence than others. So I think the more people know about what's happening in their community is important. Knowing who else if you are opening, say even with a neighbor or a child's friend, if you are opening your circle to that child's friend, think of it as you are now swimming in the same pool with not just that person, but all of the people that family is interacting with. So Crystal showed a nice picture of a social network before, and as people start to expand that social circle, they have to think of it as this cobweb or this network that has lots of tentacles. And as you bring in one new person, you're also bringing in all the people that those people are exposed to. So I think this will happen, and people are starting to do it. But I do think talking to other families to see whether their priorities align with your priorities or their goals align with your goals. And then also continuing, as you've heard repeatedly, to make sure that everyone is still practicing social distancing even when they're getting together. And obviously if they're indoors, there should be masking and just following good hand washing and other etiquette.
Excellent. Thank you, Erin. Truly appreciate it. The next question is going to go to Lisa. Lisa, I'm going to combine two questions into one because I believe it's the same theme. One of the media reporters asked, this weekend, the president's holding a large rally in Tulsa. What are your thoughts on big events like this? And does the role of indoor or outdoor play a role? With that said, another reporter asked about July 4th being around the corner. And if people want to participate in holiday gatherings, what would your recommendations be? So I believe that you can potentially answer those two questions in kind of the same response.
Sure, thank you. I'm happy to. So what we know is that outdoors is much lower risk than indoors for group activities or even just having a conversation with someone. The ambient air serves to dilute the virus and decrease the possibility of transmission. It's not zero, but so I think we still should maintain social distancing outdoors, but the indoor rally setting or any activity, going to a concert or a sporting event, I think this is not the time to do that. The risk is very high in an indoor setting. And people need to be very cautious. And as Erin outlined, the more people that are in that space, in that circle, the greater the chances that we have what we call a super spreader event, or the chance that one person who's carrying the virus could transmit it to a great number of others. And so for the upcoming holiday, I would say outdoor events, and staying away from each other to the extent possible are the preferable ways to celebrate.
Excellent. Thank you, Lisa. I appreciate that insight. The next question, I'm going to go towards Crystal. Crystal, and this is a unique question, I think so, in this time, because we, my work, we work a lot with faith-based organizations who are trying to abide by the policies of public health appropriately. And they've been faced with a conversation with us as well about how do they do contact tracing if one of their worship members becomes positive. So what are your concerns about the privacy and people potentially not being willing to share their information? How do you think that will impact contact tracing?
Yeah, I think that's a really good question. Obviously, privacy is a really important value to many of us. And so we have to have a balance here. And one thing I'd like to emphasize is that public health authorities have been doing contact tracing for decades. This is not new to them. We haven't done it on this scale before. And so they know how to handle private and sensitive information and to work with people and be empathetic. And so I think that that should hopefully tamp down some of those concerns that public health knows how to do this. But public health needs to address this directly and let people know what they're doing to keep their information safe. It's really important that people participate in contact tracing. And so I think having information out in the world about what contact tracing does and why it's effective and what it can do for us as a society as we try to control the spread of this virus is really important. So we need to do more messaging around that. And we also just need to talk to people directly on the phone and let them know what public health is doing about this. And I think that will help people understand and want to participate at a greater level.
Thank you, Crystal, and completely well said. I mean, we have to recognize that the conversations and requests by the public health officials should also be met with understanding the community's anxiety and stress and trying to find a common ground. So I think that was a great way of responding to that.
Absolutely.
I want to next move on to Sharita. Sharita, I want to ask you, I know if you had a magic wand, you'd want to cure many of things. But if we could take one step now to mitigate the health inequities that we are seeing around the pandemic, if not for medicine in general, what would your one request be?
Boy, that is a very tall order question. So, well, I think there's two things. So around the pandemic specifically, I think that we really need to have innovative public health messaging to those communities. So often if a message is coming from, the health department or a health system, that may not be heard as much, but if we can leverage, our community partners who the community already has trust with and partner with them to deliver those key messages, I think that's really, really crucial at this time. So it's using our faith communities, our organizations that, people have trusted relationships with already is really key, and doing that partnering, just like, we're doing around some of our community testing efforts, or partnering with our community partners to do that. That would be what I would say specifically related to the pandemic. So partnering with communities around public health messaging, around distribution of PPE, and also around community testing. And I would say if we're going to address the structural inequities more broadly in medicine and healthcare, not just medicine and healthcare, but society in general, that I think is important for those of us involved in healthcare to really be advocating to our legislature for policies that address those things directly. I think this is a time where our voice is really critical in that conversation.
Oh, well said, Sharita, well said. Next question goes to Shmuel. So say I had COVID-19, I recovered. One of the reporters wants to know, what is the time frame that someone can donate plasma?
So if you've been recovered for 14 days and have a negative test, or better yet, if you've been recovered for 28 days, regardless of the test, you can go ahead and donate plasma if you meet the other criteria for donations that the blood bank sets in your particular area. So that would be the criteria. As to when you can stop donating, I think that we don't know that yet. One of the things that we're doing for our trials is making sure that everybody that donates has antibody levels measured. Initially, the FDA wanted that, but people weren't quite set up to measure it, so they held off on that. And that is still, if you're donating to the Red Cross and to the major donations, you still don't need to have your antibody level measured. We think that that is going to change and should change, so that when you give the donation, you're sure that you have sort of high octane quality stuff. We know that about 80% of the people that donate blood or donate plasma after recovery have good high antibody levels, but that means that about 20% do not, and that the recipient may not get the high quality material that they are hoping for.
Understood. Thank you, Shmuel. And while there's I didn't hear any of you discuss an ending to the pandemic at any time soon. So we're all adapting to this, and one of the adaptations, of course, is birth of children. And so this goes to you, Erin. Can you speak to how high risk COVID-19 is to newborns? Any child under one, we'll leave it at that.
Sure. I mean, there are a number of people that have looked at whether or not this virus can be transmitted from mothers to children perinatally. I think we have had a number of moms who've been positive, and we have not seen any perinatal transmission here. There are concerns of postnatal transmission, so babies that may interact with moms or other sick family members shortly after birth and can contract the virus that way. Unfortunately, though, still, young children are doing very well with, most of them have had very mild illness with COVID. Most of the children that we've seen presenting with the post-COVID syndrome, or this MISC, this multi-system inflammatory condition in children associated with COVID, most of those children have not been newborns, or even in the first few months of life, they've been older children and even adolescents. So right now, although we know that pregnant moms are at high risk for having infection, many even are asymptomatic with that infection, we think the risk of transmitting at the time of birth to babies is very low. But children and infants do become susceptible once they go home and they're back in that environment where either the mother or other household contacts could be sick. So it is a very challenging environment to promote safe care for that child, making sure that they're able to access care. And this gets into some of the things that others have talked about in terms of disparities, but making sure that people still have access to care, because it's a challenging time to still get either infected or exposed people into care in a community setting. Although kids are faring well, this may be another example of unintended consequences of the COVID pandemic, is raising barriers to either well child care or other access to care that many of our patients are feeling right now, especially in in inner city settings.
Thank you, Aaron. And I want to be mindful of the hour. So I would like to take this moment to thank Lisa Maragakis, Aaron Millstone, Sharita Hill-Golden, Crystal Watson, and Shmuel Shoham. I imagine everyone, I would be standing up and giving you a round of applause. So I thank you all for taking your time out of your day to provide the media briefing today, and great informative information. Please note that we recorded the media briefing and the Q&A session today, and we'll post it in our online newsroom. All of our speakers welcome individual follow-up and interviews after today. Our media team can help facilitate this by emailing them at jhmedia@jhmi.edu. I really want to thank everyone for taking the time. And one thing for our reporter friends that I love to emphasize is you heard all these fantastic speakers talking about ways to stop the spread of the virus. You all can play a role in this as well by helping us promote our messages, our information, and that way every community gets this in order to be able to have them understand what they can do to prevent the virus from impacting them. So we want to thank you all. We're all in this together, and hopefully we can have better news in the next 6 months. So thank you all. Take care.